All right, let's proceed to the next topic, hepatitis A vaccines, with an introduction by Dr. Moore, please.
Good morning and welcome to the last of my 3 sessions for the meeting. And it's been a great privilege to chair the hepatitis work group, and looking forward to this morning's session. The hepatitis A terms of reference for our work group focused on updating the hepatitis A recommendations that were published originally in 2006. Since 2006, we've published 3 other sets of specific recommendations on hepatitis A. Back in 2009, we published recommendations related to close contacts of newly arriving international adoptees and the importance of vaccination for them. In November of 2018, we updated our recommendations for post-exposure prophylaxis and pre-exposure prophylaxis for international travel. And then earlier this year, in February 15th of 2019, we published recommendations for the use of hepatitis A vaccine in persons experiencing homelessness. In the period of time between May 2014 and now, we've had 31 meetings focused on hepatitis A vaccine topics. And just in the last 4 months, we've had 5 meetings related to the proposed update of the hepatitis A vaccine statement. So today's session will involve presentation of material that will then be voted on. There will be 3 different votes this afternoon. The first is a vote on hepatitis A routine catch-up vaccination of children through the age of 18 years, transitioning from the current wording that is more optional as a consideration for catch-up from the 2006 recommendations. A little bit of background information on this is that I think the term we're using is a large minority. 40% of states have a daycare or school mandate already. And in fact, in 2017, already more than 3 out of 4 teens had initiated the series, and over 2/3 were already fully vaccinated against hepatitis A, suggesting that there's widespread acceptance and embracing of this vaccine despite the optional recommendation for catch-up in that population. And then finally, I wanted to highlight that in 27 of 30 state immunization information systems that were tested by the American Immunization Registry Association, they already routinely forecast hepatitis A vaccine as being due for an 18-year-old who has never been vaccinated. And we appreciate ARA and their work with us to help us understand how state immunization information systems were processing recommendations about hepatitis A. And this tells us that for the vast majority of IISs, no changes would be necessary in order to embrace a routine catch-up recommendation. The second vote is a vote on HIV as a risk group for increased hepatitis A vaccine infection severity. And as you will remember from February, persons with HIV are likely to be infectious for longer when they contract hepatitis A virus, and also may have a boost, an increase in their HIV viral load during their acute infection. The good news is that people with HIV usually do respond to hepatitis A vaccination, although at a lower rate than those without HIV. And we also will show you some evidence that persons with HIV have higher rates of hepatitis A exposure than the general population, including some data that we have that are available from states that have reported on HIV status in their current ongoing outbreaks. And then finally, we have a vote on the full updated hepatitis A vaccine statement. This includes a number of modifications, including a removal of a risk group for whom we could no longer identify any excess risk, and that's persons with clotting factor disorders. So we're pleased to be able to share that as well. So the next steps for the hepatitis work group will be to continue our deliberations, but moving on to adult hepatitis B vaccination topics. And I'd like to thank the many members of the hepatitis work group for your active engagement in these discussions the last few months, and especially thank our lead, Noelle Nelson, with the hepatitis division. There also are a lot of folks involved with CDC and other divisions, as well as Doug Campus-Alcolt, who helped with the grade and evidence recommendation framework. And I'd like to highlight Mona Alea and Mark Wing for their help as well. So at this point, I'll turn it over to Dr. Nelson for her to present the information that will prepare you for our vote this afternoon. Thank you.
Thank you, Dr. Moore. Good morning. Today's presentation will include an overview of hepatitis A virus epidemiology and hepatitis A vaccines, a presentation of the evidence to recommendation framework for catch-up hepatitis A vaccination, a review of the evidence to recommendation framework that was presented at the February 2019 ACIP meeting for persons with HIV as a recommended risk group for hepatitis A vaccination, updates for pregnancy and clotting factor disorders, then the proposed hepatitis A recommendations and updates deliberated on by the work group will be presented. First, I will discuss hepatitis A epidemiology. Data collection for hepatitis A started in 1966. The highest number of hepatitis A cases reported was in 1971, when approximately 60,000 cases were reported at a rate of 30 cases per 100,000 population. Vaccine was recommended in 1996. From 1996 through 2011, there was a 95.5% decrease in reported cases. The number of reported cases fluctuated slightly from 2011 through 2015 due to outbreaks, but has started to increase sharply since then. In 2017, there were 3,365 reported cases. The recent increases in reported cases can be seen more clearly here. The rate of reported cases was 1 case per 100,000 population in 2017 nationally, the highest rate since 2007. Looking at the rates of reported cases by age group, in 2017, persons aged 30 through 39 years had the highest rate at 2 cases per 100,000 population, followed by persons aged 40 through 49 years at 1.53 cases per 100,000 population, and persons aged 20 through 29 years at 1.45 cases per 100,000 population. Widespread outbreaks of hepatitis A have occurred across the United States since 2016. Since the outbreaks were first identified, 24 states have publicly reported the following as of June 21, 2019. 20,512 cases, 11,776 hospitalizations, or 57% of cases, and 194 deaths. The number of deaths due to hepatitis A virus infection had been very low historically, though disease severity is known to increase with age. The high number of deaths in the current outbreaks is likely due to comorbidities and underlying health conditions of the hepatitis A cases, something that requires further investigation. Here, data from the National Notifiable Diseases Surveillance, or NNDSS system, shows hepatitis A incidence rates have increased dramatically in the wake of the outbreaks. As shown on the left, in 2015, during a non-outbreak year, the national hepatitis A incidence rate was 0.4 cases per 100,000 population. Shown on the right, based on preliminary data, the national hepatitis A incidence rate increased to 3.8 cases per 100,000 population during 2018. The increased incidence rates are even more dramatic when compared at the state level. In 2018, state hepatitis A incidence rates ranged from 0 cases per 100,000 population in Alabama, Montana, and North Dakota to 112 cases per 100,000 population in West Virginia. Here, this latest national EpiCurve was also created with NNDSS data. Due to reporting lag and the relatively long incubation period of the virus, the far right side of the curve is subject to change. A summary of the changing epidemiology of hepatitis A is as follows. Asymptomatic children were associated with hepatitis A virus transmission in past outbreaks in the pre-vaccine era. Now, recent outbreaks are occurring primarily among adults. Among states with publicly available case information by age group, the median age of hepatitis A cases is in the 30 through 39-year age range, with a substantial percentage of cases aged in the 20 through 29 and 40 through 49-year age range. In the current outbreaks, disease severity is thought to be due to comorbidities and the poor underlying health of many hepatitis A virus-associated cases, including persons co-infected with hepatitis B and hepatitis C. Many cases have occurred among persons who use drugs and persons experiencing homelessness. Person-to-person contact, crowding, and poor hygiene are thought to contribute to virus transmission among these groups. Increases of hepatitis A viral infections have also occurred among men who have sex with men. These outbreaks are estimated to cost tens of millions of dollars in healthcare expenditures. Though person-to-person spread is now the predominant mode of hepatitis A virus transmission, sporadic foodborne outbreaks also continue to occur. Now I will talk about hepatitis A vaccines. 2 inactivated single-antigen hepatitis A vaccines are licensed in the United States, Havrix in 1995 and Vacta in 1996. A combined Hep A, Hep B vaccine, Twinrix, is also available in the United States for adults aged greater than or equal to 18 years. In a clinical trial, Vacta's efficacy in protecting against clinical hepatitis A was 100% among greater than 1,000 New York children aged 2 to 16 years who received 1 dose while living in a community with a high hepatitis A disease rate. Havrix's efficacy in protecting against clinical hepatitis A was 94% among greater than 38,000 Thai children aged 1 through 16 years who received 2 doses 1 month apart while living in villages with high hepatitis A virus disease rates. Not shown on this slide, after 3 doses of Twinrix, antibody responses are equivalent to responses seen after the single antigen vaccines administered separately on standard schedules. All licensed vaccines are highly immunogenic when administered to children and adolescents. 97 through 100% of persons aged 2 through 18 years had protective levels of antibody 1 month after receiving the first dose. 100% had protective levels 1 month after the second dose with high geometric mean titers, or GMTs. All licensed vaccines are highly immunogenic in persons aged greater than 18 years when administered according to the recommended schedules. Protective antibody levels were identified in 94 to 100% of immunocompetent adults 1 month after the first dose. After the second dose, all persons had protective levels of antibody with high GMTs. Antibody to hepatitis A virus has been shown to persist in vaccine recipients for at least 22 years in adults administered inactivated vaccine as children with a 3-dose schedule, which has been shown to be equivalent to the current 2-dose schedule. At least 20-year antibody to hepatitis A viral persistence was demonstrated among adults vaccinated with a 2-dose schedule as adults. Detectable antibodies are estimated to persist for 40 years or longer based on mathematical modeling and antibody to hepatitis A viral kinetic studies. Protection following natural infection is lifelong and may also be following vaccine. In pre-licensure trials, adverse reactions to Havrix, Vacta, and Twinrix were mostly injection site reactions and mild systemic reactions. Post-marketing surveillance for adverse events following receipt of hepatitis A vaccines has been performed primarily by VAERS and VSD. No unusual or unexpected safety patterns were observed for any of the hepatitis A vaccines licensed in the United States. Additional detailed safety data was presented in grade presentations at the February 2018, October 2018, and February 2019 ACIP meetings, and additional information on vaccine safety and pregnancy will be shown later in this presentation. Hepatitis A vaccination was introduced incrementally in the United States from 1996 through 1999. In 1996, vaccine was recommended for children at 2 years in communities with high rates of disease and children at 2 years and older children in outbreaks. In 1999, vaccine was recommended for children at 2 years in 11 states, shown in dark purple, with average annual hepatitis A rates of 2 times the national average, or greater than or equal to 20 cases per 100,000 population. Vaccine was considered in 6 states, shown in light purple, with rates above the national average, or greater than or equal to 10 cases per 100,000 population. Routine vaccination was recommended in 2006. Universal early childhood vaccination was recommended for use at age 12 through 23 months in all states. Existing vaccination programs for children ages 2 through 18 years were recommended to continue. Catch-up vaccination in outbreaks and areas with increasing disease rates could be considered. Any person wishing to obtain immunity is recommended for hepatitis A vaccine. In addition, groups at increased risk of hepatitis A viral infection or severe hepatitis A viral disease are recommended to receive hepatitis A vaccine. These groups include travelers, men who have sex with men, users of injection and non-injection drugs, persons with clotting factor disorders, which is proposed for removal and will be discussed later, persons with occupational risk for infection, persons who anticipate close personal contact with an international adoptee, persons with chronic liver disease, and today we will discuss workgroup deliberations regarding adding persons with HIV as an indication for vaccination. Next slide, please. The hepatitis A vaccine coverage in 2017 was as follows. For children aged 19 through 35 months, greater than or equal to 2-dose coverage was 59.7%, and greater than or equal to 1-dose coverage was 86%. The greater than or equal to 2-dose coverage is likely underestimated, since the first dose can be given up to age 23 months, with the second dose administered at least 6 months after the first. For adolescents aged 13 through 17 years, greater than or equal to 2-dose coverage was 68.4%, and 1-dose coverage was 77.2%. For adults greater than or equal to 19 years, greater than or equal to 2-dose coverage was 10.9%, and higher for risk groups, 17.7% for travelers and 20.8% for persons with chronic liver disease. These rates are slightly higher when considering adults in the limited range of 19 through 49 years. This slide shows estimated hepatitis A vaccine coverage in 2017 in relation to other selected vaccines among adolescents aged 13 through 17 years. Tdap, greater than or equal to 1-dose coverage, was 88.7%, the red line on top. Coverage with greater than or equal to 1 dose of quadrivalent meningococcal conjugate vaccine was 85.1%, the dashed blue line under the red line. Coverage for greater than or equal to 1 and greater than or equal to 2 Hep A vaccine coverage follows at 77.2% and 68.4% respectively, the orange and lime green lines. Coverage with greater than or equal to 1 dose of HPV vaccine, which was introduced in 2011, was 65.5%, the yellow line. And coverage with greater than or equal to 2 doses of quadrivalent meningococcal conjugate vaccine and greater than or equal to 3 doses of HPV coverage are lower. Thus, coverage for Hep A vaccine among adolescents aged 13 through 17 years is comparable to other vaccines administered to adolescents for which a routine catch-up recommendation exists. The footnotes for this slide are available on backup slides. As of October 2018, greater than 40% of states have introduced mandates for daycare or daycare plus school or school alone, compared to 28% of states in 2011. The increase in mandates is likely partially responsible for the increase in adolescent Hep A vaccine coverage. Now I will present catch-up hepatitis A vaccination. Currently, ACIP recommends hepatitis A vaccination for all children aged 12 through 23 months, with a shared clinical decision-making recommendation for catch-up vaccination. The work group proposes strengthening this recommendation to include routine catch-up. The proposed recommendation is as follows. ACIP recommends that all children and adolescents aged 2 through 18 years who have not previously received Hep A vaccine be vaccinated at any age, i.e. children and adolescents are recommended for catch-up vaccination. This language aligns with the hepatitis B vaccine statement language. The policy question and PICO for catch-up vaccination are as follows. Should hepatitis A catch-up vaccination be recommended for children aged 2 through 18 years? Population, children aged 2 through 18 years. Intervention, hepatitis A vaccination. Comparison, hepatitis A vaccination based on shared clinical decision-making. And the outcomes of interest, hepatitis A infection and adverse events. Now I will present the evidence to recommendation framework for catch-up vaccination. Is the problem of public health importance? The work group judged yes. The rate of reported acute hepatitis A cases in 2017 was 1 case per 100,000 population, 1.45 cases per 100,000 population among young adults aged 20 through 30 years compared to 0.87 cases per 100,000 population in 2016. The incidence was 2 cases per 100,000 population among adults aged 30 through 39 years compared to 0.92 cases per 100,000 population in 2016, representing the highest number of hepatitis A cases and more than double the 2016 rate for this age group. In 2017, national hepatitis A vaccine greater than or equal to 2-dose coverage was 68.4% for adolescents aged 13 through 17 years, and 1-dose coverage was 77.2%. For children living in states where routine vaccination at 12 through 23 months was first recommended in 2006, who were 1 year of age in 2006, or 12 to 13 years old in 2017 when these coverage data were collected, and thus were not subject to the universal recommendation for children aged 12 through 23 months. However, coverage among these children is only slightly lower than the total cohort at 61% for greater than or equal to 2 doses and 71% for greater than or equal to 1 dose. Despite catch-up vaccination being based on shared clinical decision-making, the overall coverage in the 13 through 17-year-old age cohort demonstrates that catch-up is occurring. As previously stated, the ongoing hepatitis A viral outbreaks have caused a substantial number of cases, hospitalizations, and deaths. Among states with publicly available case information by age group, the median age of hepatitis A viral cases is in the 30 range, with a substantial percentage of cases in their 20s and 40s. Vaccinating adolescents who could be at risk for hepatitis A viral infection at present or in the future, example, persons who use drugs, persons experiencing homelessness, and travelers, can have an impact on improving coverage among young adults. How substantial are the desirable anticipated effects? The work group judged large. Havrix and Vacta are highly immunogenic when administered to children and adolescents according to multiple schedules. The immunogenicity and long-term protection data on this slide were mentioned earlier in this presentation. Catch-up vaccination is a way to increase herd immunity and ensure that the percentage of children and adolescents who miss vaccination as scheduled or who were born outside of the routine vaccination cohort are protected. Since the implementation of risk-based vaccination in adults has been poor, catch-up vaccination will more rapidly increase the proportion of adults with risk factors who are protected. Hepatitis A vaccination in childhood has demonstrated long-term protection. How substantial are the undesirable anticipated effects? The work group judged minimal. Rates of adverse events following Havrix, Vacta, and Twinrix vaccination were similar to those seen with separately administered vaccines. No unusual or unexpected safety patterns were observed in VAERS for any hepatitis A vaccines. Limited data from studies conducted among adults indicate that simultaneous administration of hepatitis A vaccine with diphtheria, poliovirus, tetanus, typhoid, cholera, Japanese encephalitis, rabies, or yellow fever vaccine does not decrease the immune response to either vaccine or increase the frequency of reported adverse events. Do the desirable effects outweigh the undesirable effects? The work group judged that the intervention is favored. Hep A vaccination affords long-term protection against hepatitis A viral infection. Disease severity increases in older persons and persons who are immunocompromised, have chronic liver disease, or other underlying health conditions. Over 20 years of safety monitoring have shown no known safety concerns. Earlier Hep A vaccination among healthy children and adolescents provides protection against infection before persons developed increased risk or hepatitis A viral-associated complications. What is the overall certainty of this evidence for the critical outcomes? There was no included studies for the effectiveness of the intervention nor the safety of the intervention. GRADE was not used to evaluate the evidence for the following reasons. Hep A vaccine has been recommended for administration to children since 1996. Hep A vaccine has been recommended for catch-up vaccination based on shared clinical decision-making since 2006. The efficacy and safety of Hep A vaccines has been evaluated and well documented. There are no known safety concerns with Hep A vaccines based on over 20 years of use. Does the target population feel that the desirable effects are large relative to undesirable effects? The work group judged probably yes. In 2017, hepatitis A coverage among adolescents is as previously stated, and substantially higher than 2008 coverage of 25.3% greater than or equal to 2 doses and 36.2% or 1 dose. This demonstrates substantial catch-up implementation and acceptance despite a recommendation based on shared clinical decision-making. Although specific studies of desirability among older children or parents for hepatitis A vaccine have not been conducted, the fact that almost 80% of adolescents had initiated the hepatitis A vaccine series by 2017 demonstrates a demand and preference for protection against hepatitis A. The Hep A vaccine adolescent 2-dose coverage is comparable or greater than other vaccines with a routine catch-up schedule, which provides further evidence of acceptability by the target population. Is there important uncertainty about or variability in how much people value the main outcomes? The work group judged probably no important uncertainty or variability. The high coverage rate, despite this recommendation being based on shared clinical decision-making, provides strong and consistent evidence that most parents' patients believe that it is important as some routinely recommended vaccines. Is the intervention acceptable to key stakeholders? The work group judged probably yes. As previously stated, the number of states with mandates increased from 28% in 2011 to greater than 40% in 2018. These states choose to achieve higher rates of vaccine coverage for children, even though CDC has not strongly recommended hepatitis A vaccine catch-up. During the hepatitis A virus multi-state outbreaks, educational communications and 2 health alert network advisories have been disseminated, increasing the level of awareness among all clinicians in states and the general public about the threat of person-to-person spread of hepatitis A and the value of a vaccine that is thought to provide lifelong protection. The hepatitis A adolescent 2-dose coverage is comparable or greater than other vaccines with routine catch-up schedule, providing further evidence of acceptability by key stakeholders. Is the intervention a reasonable and efficient allocation of resources? The work group judged probably yes. A cost-effectiveness model used to assess nationwide routine hepatitis A vaccination was adapted to assess the cost-effectiveness of catch-up Hep A vaccination and was presented at the June 2017 ACIP meeting. The findings of the study were that over the lifetime of the cohort, catch-up vaccination would reduce the total number of infections relative to the baseline by 741, while increasing doses of vaccine by 556,989. Across the age cohorts, the cost-effectiveness of catch-up vaccination was most favorable at age 12 years due to splitting administration costs with other vaccines, resulting in an incremental cost-effectiveness ratio, or ICER, of 189,000 per quality gained. Catch-up was more effective when it was assumed to replace more adult vaccination and is targeted to children in late adolescence because there is lower vaccine coverage and a higher probability of symptomatic disease among older children, less discounting of future costs of disease, and less delay in averting adult vaccination costs. The impact of vaccination on the ICER was most sensitive to the discount rate, which was 3%, followed by the rate of adult vaccination. The model had the following limitations. The model was based on hepatitis A incidence from 2008 through 2012. The conclusions strongly tied to factors such as vaccine uptake and disease transmission patterns, which may change over time, altering future cost. The model also excluded herd immunity effects of vaccination. The incremental cost of catch-up now would be more favorable because the adolescent vaccination coverage rates are much higher than when the study was conducted. 2009, one-dose coverage was 42%, and two-dose coverage was 29.5%, compared to the 2017 coverage. Achieving 80 to 90% coverage among teens would require a much smaller number of additional vaccines given. In addition, the hepatitis A viral incidence overall is higher due to the ongoing multi-state outbreaks. 0.5 cases per 100,000 in 2012, 1 case per 100,000 population in 2017, and rates are known to be much higher 2018 and 2019 based on preliminary outbreak data. A formal cost-effectiveness analysis was not done. However, a cost example is as follows for a target hepatitis A vaccine series completion percentage of 80% and target hepatitis A vaccine series initiation of 90%. The example assumes that 2017 coverage rates apply to all. Younger adolescents are known to have a higher coverage, however. And 100% of one-dose recipients complete the series when calculating the cost of 80% completion. 50% of the vaccination cost is at the private price, or $32.89, and 50% at the CDC price, or $20.52. To achieve 90% hepatitis A vaccine series initiation, 3.2 million persons would need to be vaccinated with one dose of hepatitis A vaccine at a cost of $52.8 million private and $33 million CDC. To achieve 80% hepatitis A vaccine series completion, 2.2 million additional persons would need to be vaccinated with one dose, and 701,000 persons would need to be vaccinated with two doses at a cost of $59.3 million private and $37 million CDC. Is the intervention feasible to implement? The work group judged yes. As Dr. Moore already stated, of the 30 registries that the American Immunization Registry Association were able to query to test forecasting algorithms, 27 or 90% already routinely forecast hepatitis A vaccine as being due for an 18-year-old who has never been vaccinated, and all 30 algorithms forecast a second dose in any 18-year-old who has had one dose. Therefore, 90% of tested registries would not have to change to implement routine catch-up. Routine hepatitis A catch-up already exists in states with school mandates. The New York City Bureau of Health recommends that all children and adolescents not previously vaccinated should receive the two-dose hepatitis A vaccine series by their 19th birthday for lifetime protection. And there are opportunities to administer hepatitis A vaccine to adolescents concurrently with vaccines protecting against other infections, such as HPV and meningitis. A 2014 survey found that if ACIP made a recommendation for catch-up Hep A vaccination at health maintenance visits for all children 2 through 18 years of age, 96% of pediatricians and 79% of family medicine physicians reported it would be very feasible to routinely assess Hep A vaccination status and vaccinate children and adolescents who were not fully vaccinated. An additional 4% and 19% respectively indicated it would be moderately feasible. Since then, increased education and awareness among providers and the public due to the ongoing hepatitis A viral outbreaks have likely decreased barriers to vaccination. The work group judged that the desirable consequences probably outweigh undesirable consequences in most settings. Is there sufficient information to move forward with the recommendation? The work group judged yes. Policy options for ACIP consideration. The work group proposes that ACIP recommends the intervention. Again, the proposed recommendation is as stated.
Dr. Nelson, could we please stop here for a minute? I hate to interrupt your excellent presentation. Go back one slide, and let me ask the members, one more slide. Let the members of the voting committee see if there are any questions or comments at this point. Yes, Dr. Atmore.
So I'd like to go back even, well, to the balance of consequences and the work group's recommendation for a probable yes. What detracted from a definitive yes? What were the concerns of the work group that weighed in as a probably yes rather than
So it's slide 35.
straight yes? That was slide 35. Well, in our handout anyway.
The work group deliberations discussion was about being more conservative on saying probably yes instead of yes due to the past cost effectiveness analysis that was presented. But the work group was unanimous in agreeing that the catch-up vaccination should be proposed to be recommended.
Kelly, sorry, Dr. Moore.
Thank you. I will clarify, actually, there was no hesitation whatsoever about this on the work group. Everyone was unanimously strongly in favor of a routine recommendation for catch-up. In fact, we had the conversation about which box to tick, and the thought on the work group was, well, if we were so definitive, we would probably get questions from the committee about why we were so definitive. But Robert, you've stuck us because now we tried to hedge, and you're calling us on that. But in fact, there were no concerns expressed. And when we looked back on the economics, what we really felt was that the economic analysis done back in 2014 really no longer reflects the conditions today, and so no formal economic analysis was done, but we knew things would look much, much better today than they appeared back then. So I hope that helps.
I was afraid people would think we're hedging too much, and so when there's something to be definitive about, let's do that.
Yes, Dr. Messier.
Yeah, I'm just going to try to make sure that I get the rationale, because I think this was a very complete presentation, but typically when we get to this point, the evidence framework sort of is simplified because we've talked about it so much. And so I just want to make sure that I get the rationale in a concise way here. Since the last time we've looked at this, we've had an increase in these large hepatitis A outbreaks, and in the cases, 40% of the patients don't have an identifiable risk factor. And even though the current intervention for the current outbreaks is more targeted towards adults, because that's where the risk group are, and likely will be controlled with the controlled intervention, we have coming up a cohort of kids, and hepatitis A is cyclical, and as they get to adulthood, we would expect there to be another cycle of outbreaks. So the goal here is to catch them up on their vaccination at a time when we know that they are more likely to seek medical care, with the expectation that the vaccine will last long enough that when they get to their risk period, they will then be protected. Is that right?
That is a wonderful summer, Dr. Messonnier. So I think that our great concern was that our longstanding risk-based recommendations for adults have just been very poorly implemented for many reasons, and many of the adults who find themselves at risk later on are often ones with poor access to health care and utilization of health services. And this vaccine can provide long-term, possibly lifelong protection, and we have an opportunity to have the entire cohort cared for before they become adults and acquire risk factors or express risk factors. So that was the strong motivation of the group.
Dr. Hunter.
So this is another example, along with HPV and pneumococcal conjugate vaccine, of the importance of vaccinating children to protect adults. I just want to make sure that we're clear that this catch-up recommendation doesn't detract in any way from the young childhood routine vaccination recommendation. I don't think that there's any suggestion that it should.
Dr. Moore, if you want to respond.
Yes, certainly. I'll be happy to respond to this. I think what is quite evident is that close to 80% of teens have already initiated the series, and there are many opportunities for immunization now and during adolescence where that catch-up can occur. But we actually had the conversation and discussed whether we should just have a blanket hepatitis A vaccination sometime before you become 18, and there was a strong feeling that we should maintain the routine recommendation of that routinely children should be vaccinated at the earliest opportunity to protect them, which is age 12 to 23 months, and that this is only for catch-up for children who missed out on that. And in fact, the current cohort, the oldest teens, were not subject to that routine recommendation in early childhood. So they were caught up in many cases over time, but they were not actually subject to that original recommendation.
Dr. Maldonado.
Yeah, so I'm a pediatrician who went through some of those early days, especially in California, where we had the risk-based vaccinations, and it was extremely, extremely confusing to try to, for pediatricians, and we were constantly being asked, which kids do we vaccinate? Who's high risk? Who's really not? Because it's not very clear who might be at high risk. I mean, I believe it had to do with the incidence in your county, and so it was really complicated. So I think this is a great opportunity, and we do see, I mean, we know what's happening out there with these patients, and we've seen a lot of deaths in California, and a lot of these, I do think that this is an opportunity to really stem a fatal disease that's easily preventable. So I think this recommendation would be really helpful for not only adult internists, but pediatricians as well, and I think they'd be fine with it.
Dr. Lee.
Thanks. I just wanted to follow up a little bit on some of the points that were made, just because looking at, it's been a long time, I think, since this group has looked at the economic models. I think the incremental cost effectiveness ratios would look much better if herd immunity were accounted for sure. And certainly if we were to think about this as a holistic program where we're actually capturing adolescents now and really avoiding the need to then track down high-risk adults, as it was mentioned before. So just in terms of at least the economic analysis, I'm confident that it would actually be very cost-effective if we were to consider those 2 points.
Dr. Szilagyi.
Actually had similar questions to Dr. Atmar about why this was probably, and I was, because it seems pretty definitive to me, and also I was impressed with the feasibility data that you presented, Noel. But I was just wondering, why didn't we have a formal economic analysis? Because we usually do with the evidence to recommendations, although you did present some, some data. So I was just wondering why we didn't do it. Was it that there were too many assumptions?
So the cost-effectiveness analysis was done, presented in June 2017. However, it wasn't updated to represent the changing epidemiology.
Dr. Walter.
Yeah, as a general pediatrician who's done catch-up vaccination for a number of years, I'm really glad to see that we're moving forward with a full recommendation to do catch-up vaccination. One thing that's curious is looking at the teens, the second dose coverage, the disparity between that and looking at younger kids, the gap is much narrower in the older adolescents, and I just wonder your thoughts on that.
We believe it's due to underestimation of the 2-dose coverage in the younger 19 through 35 months, because if they're vaccinated close to that 23 months, and the range is they can be vaccinated up to 18 months later for the second dose, they might be missed in that survey.
Are there any other questions or comments? All right, none being, thank you, Dr. Nelson. Would you please continue with your excellent presentation?
Thank you. I will move on to persons with HIV. The proposed recommendation for persons with HIV is as follows. ACIP recommends that all persons with HIV aged greater than or equal to 1 year be vaccinated with hepatitis A vaccine. The following policy question and PICO were presented to ACIP in February 2019 and are as follows. Should routine 2-dose vaccination to prevent hepatitis A virus infection be given to HIV-positive persons, or 3-dose vaccine when combination vaccine is used? Population, adult HIV-positive persons, regardless of another indication for vaccination. Intervention, routine 2-dose hepatitis A vaccination. Comparison, no routine 2-dose Hep A vaccination. And outcomes of interest, hepatitis A infection, mild adverse events, and serious adverse events. At the end of 2016, an estimated 1.1 million people aged 13 years and older had HIV infection in the United States. When persons with HIV are co-infected with hepatitis A virus infection, they experience higher hepatitis A viral loads and a prolonged duration of hepatitis A viremia than persons without HIV infection. In addition, hepatitis A virus infection has a potential to increase HIV viral loads and HIV transmission. Persons with HIV respond to hepatitis A vaccine with a seroconversion rate of 48.5% through 94%, following a 2-dose monovalent vaccine schedule. And factors associated with a protective antibody response in persons with HIV include a CD4 count greater than 200 and a low HIV RNA viral load. In 2017, the number of new HIV diagnoses was 38,739 and was mostly among adults. The highest numbers were among adults aged 20 through 39. CDC classifies HIV diagnoses into transmission categories to which transmission may be attributed. The categories shown in red represent existing recommended risk groups for hepatitis A vaccination. Based on this classification, approximately 76% of persons living with HIV already have another risk group for which hepatitis A vaccination is recommended. We use the Medical Monitoring Project, or MMP, which looks at a nationally representative sample of persons living with HIV to answer the question, what percentage of persons with HIV do not have an existing risk factor for which hepatitis A vaccine is recommended? The percentage of persons living with HIV without a recommended risk group for hepatitis A vaccination is higher when looking at more specific risk factor data. MMP estimates that 60% of persons with HIV had a risk factor of MSM, injection or non-injection drug use, chronic liver disease, clotting factor disorder, or homelessness in the past 12 months. Data were not available for proportions of persons with HIV for other recommended risk groups. And those are 40% of persons with HIV in the United States do not have an ACIP recommended indication for hepatitis A vaccine. The grade and evidence recommendation framework were presented at the February ACIP meeting. The grade summary is as follows. The benefit outcome for hepatitis A infection for randomly controlled trials was graded as an evidence type 2 and downgraded for indirectness. The benefit outcome for hepatitis A infection for observational studies was graded as an evidence type 4, downgraded for indirectness. The harm outcome, mild adverse events for randomly controlled trials is graded as evidence type 1. The harm outcome for mild adverse events for observational studies was graded as evidence type 3, and a harm outcome for serious adverse events for randomized controlled trials was graded as an evidence type 3 and downgraded for imprecision. The harm outcome, serious adverse events for observational studies was graded as an evidence type 4 and downgraded for imprecision as well. The workgroup judged that the desirable consequences probably outweigh undesirable consequences in most settings. Policy options for ACIP consideration, the workgroup proposed that ACIP recommends the intervention. Additional information regarding hepatitis A virus infection among persons with HIV is shown here. Among people with a diagnosis of HIV who received outpatient HIV medical care during 2014 through 2017, the prevalence of diagnosis of hepatitis A recorded in the medical record at the primary HIV care site during a 2-year period of 0.48%. Additional information regarding the hepatitis A outbreaks in persons with HIV is shown here. HIV co-infection outbreak data are publicly available for a limited number of states. Among 249 reported cases of hepatitis A in Tennessee, 11 or 4% of patients were persons with HIV. Among 359 reported cases of hepatitis A in Massachusetts, 14 or 4% were persons with HIV, and among 85 reported cases in Illinois, 7 or 8.2% were persons with HIV. This shows a clear excess of hepatitis A viral infection risk among persons with HIV. The U.S. population estimate is 327 million. Persons with HIV are less than 0.34% of the general U.S. population. Several questions were asked by the ACIP committee at the February 2019 meeting. I will provide explanations for selected questions. Is there value in knowing laboratory criteria before administering the vaccine? Should antibody to hepatitis A viral titers be checked periodically after vaccine administration? Will CD4 count thresholds be utilized for the recommendation of hepatitis A vaccination among persons with HIV? And what are the costs of vaccinating persons with HIV? I'll answer the first set of questions here. Next slide, please. Since response to vaccine might be reduced in persons with HIV who are immunosuppressed or have lower CD4 counts, post-vaccination testing is proposed to be recommended for all persons with HIV at least 1 month after vaccination. Although patients with lower CD4 counts may not respond as well to the vaccine, in order to avoid missed opportunities to immunize, immunization against hepatitis A should not be delayed until the CD4 count exceeds a particular threshold. Persons with HIV who do not respond to vaccine should be considered susceptible to hepatitis A viral infection and counseled about precautions to prevent infection and the need to obtain immunoglobulin post-exposure prophylaxis for any known or likely exposure to a hepatitis A viral infected person. The cost of adult vaccines are shown here, approximately $30 CDC cost and $68 private cost. Vaccine administration fees range from a few dollars up to $20 from best available information. How much would it cost to vaccinate persons with HIV? A formal cost-effectiveness analysis was not done for persons with HIV as a risk group for Hep A vaccination. Considering that approximately 400,000 persons with HIV are potentially unvaccinated against hepatitis A vaccine, a very basic calculation, assuming 50% vaccine uptake, is as follows. 200,000 times 68, or the private cost of 1 dose, equals 13.6 million. 200,000 times 136, or the price of 2 doses at the private price, is 27.2 million, in addition to a small administration fee. Considerations are that not all persons with HIV will be vaccinated at the same time. The cost would be spread out over time. Vaccination in this high-risk population would help disrupt outbreaks by providing increased herd protection. In an outbreak response, the associated costs, including healthcare expenses and deferred activities, is substantial. Again, the proposed recommendation for persons with HIV is as follows. ACIP recommends that all persons with HIV aged greater than or equal to 1 year be vaccinated with hepatitis A vaccine.
So again, Dr. Nelson, I'm going to ask you to excuse my rudeness in interrupting your presentation, and I'd like to turn to the voting members to see if they have any questions. Dr. Atmar.
So I have a couple of questions related to the antibody testing. And one relates to the proposal to do post-vaccination serologic testing at least 1 month after vaccination. And I guess I would ask the question of what would be done with that information should a person be seronegative. Is there a proposal to boost? And then on the converse side, if there's already a prevalence of seropositivity, there is already a prevalence of seropositivity in persons with HIV who would thus presumably not be at risk and would not require vaccination. Was there consideration for screening, and would that, for seropositivity and only vaccinating those who are seronegative, or from a cost benefit, was that thought not to be worthwhile?
Sure. So for post-vaccination testing, for those who are not positive, and I'll get to those slides a little later, the proposal is to then counsel that person about risk of exposure and inform them that they would need immunoglobulin in case they were exposed or concerned about exposure, and then there's potential for revaccination, but we were not just giving clinical guidance on that and not proposing to recommend that there would be continued revaccination. And then your second question was about pre-exposure testing. So again, in the pre-exposure, we are giving the information that persons in high-risk groups could be tested, but that should not deter vaccination or preclude vaccination in those who could not be tested.
Dr. Walter.
I think Dr. Atmar had the same question, but just one clarification that testing will be done after series completion. Is that not just one dose? Okay.
Yes, point, thank you.
So let me ask a question here. How much additional cost would the testing add to your figures for cost of vaccination?
The cost of antibody testing, I believe, is about $30, but not positive on that. No. Dr. Wester, you are?
Dr. Atmar wants to.
Well, I think it's probably 30 to 50, but I mean, the point being, if there's high seroprevalence, then it could be cost savings because you're not vaccinating. So if there's low seroprevalence, then it's added costs. But if you can avert unnecessary vaccination, then it could potentially be cost savings depending upon the seroprevalence.
Understood. Dr. Moore, do you want to
Sure. We did have conversations about that and felt like it was not something for the ACIP to weigh in on, but that could be provided as clinical considerations. It's going to depend on the patient population. There's not a uniform answer for everyone who has HIV. And in certain clinical settings, it may be convenient and easy to screen in advance, and they may do that. But we didn't want that to be perceived as any kind of barrier to immunization if routine immunization was already going to be done. The other thing about post-vaccine serologic testing is that it was intended to harmonize with the hepatitis B post-vaccine serologic testing that's already recommended for these folks after they receive the hepatitis B series. And so the idea is that that could be tagged on at the same time. But we did not have data to go into recommending booster doses and that sort of thing, so we didn't go there.
Kelly, can I just ask, I think there's maybe a language issue here. If you go back to the laboratory post-vaccination testing slide, I mean, it doesn't read, can you go back to slide 54? Go back a couple more. It doesn't exactly read like you said it. Slide 54, right there. Sorry, 59, yeah. It doesn't read like you said it exactly, right? This language.
For which part?
About what to do about it, right? What you said is it's post-vaccination testing is proposed to be recommended. it's actually not a recommendation, it's clinical guidance.
So I will talk about that on slide 85, which I haven't gotten to yet. Testing for the presence of antibody to hepatitis A viral antibody after vaccination is recommended for persons whose subsequent clinical management depends on knowledge of their immune status. Persons with HIV and other immunocompromised persons, example, persons with hematopoietic stem cell transplant recipients, persons receiving chemotherapy. Testing should be performed at least 1 month after administration of the final dose of the vaccine series with total antibody to hepatitis A virus or IgG antibody to hepatitis A viral assays. And then it continues.
I'm sorry, we don't have that slide in our.
Yeah,
It's in your packets, it's slide 80.
There you go.
85.
No, it's not.
Well, it's listed as slide 80, I'm sorry, page 40. There may be some incongruency
Can you
between
pull
the
up slide
two
85,
packets.
85.
I just would say that I'm not sure that the language is correct here. It's not, it's recommend. I mean, if this is clinical guidance, then we could, I mean, we're not asking you to vote on this language, but there's a way perhaps to articulate this so it sounds more like what Dr. Moore described, which is clinical considerations as opposed to a recommendation, if that would help folks consider this.
Sure, sure. And also with respect to the pre-vaccine testing that Dr. Atmar was suggesting, we weren't wanting to recommend that. That's another clinical consideration for an individual.
I just wanted to add that the ACIP members have been sent a draft of this statement, but there's still plenty of time to incorporate some of these comments and address those, even if you vote to approve the statement today.
Dr. Lee.
I was just going to say, I'm fully in favor of really thinking about this population as one that we should be targeting. So with that said, I think it would be helpful maybe in this instance, unlike the other, to have a little bit more, and I don't think this will affect my decision, but just to state that I think modeling in this case might have been helpful just to give us a little bit more insight into the questions that Dr. Atmar raised, and also because it's incorporating clinical guidance around testing and sort of getting clarity around that and what the benefit really would be. This is a smaller population. They've been involved in outbreaks, so I think from an outbreak perspective, again, it's still really important to do. But just from, again, a 10,000-foot perspective, I think that would have been helpful.
Dr. Stevens, sorry.
I too had concerns about the post-vaccination language to some degree. My question, though, and maybe you answered it, was about what happens with revaccination in those, maybe there's no data. Okay, so that's there's no data on revaccination. It seems like an opportunity.
Dr. Hunter? Did you? No? Okay. Any other comments, questions? Okay. Dr. Nelson, please continue.
Thank you. Slide 63, please. Now I will talk about pregnancy. Next slide, please. Okay, thanks. Pregnancy has been on the recommended adult immunization schedule by medical condition and other indications since 2005 through 2006 if another risk factor is present. A review of the published data on hepatitis A during pregnancy found that hepatitis A infection during pregnancy is associated with gestational complications. Example, preterm labor, placental abruption, premature rupture of membranes. Generally, infants born to mothers with hepatitis A viral infection are healthy, but there are rare exceptions. There is no increased risk of maternal or infant mortality after Hep A vaccination in pregnancy. A VIIRS study by Morrow et al. In 2014, based on VIIRS reports of adverse events in pregnant women who received Hep A or Hep A-B vaccine from January 1st, 1996 through April 5th, 2013, found no unusual clustering of birth defects. VIIRS received 139 reports of adverse events in pregnant women. 7 were classified as serious. 65 did not describe any adverse events, and no maternal or infant deaths were identified. The review of VAERS reports concluded that no concerning pattern of adverse events in pregnant women or their infants following maternal hepatitis A or hepatitis A/B immunizations during pregnancy was identified. Preliminary results of a large, ongoing retrospective cohort study in the Vaccine Safety Data Link were presented to the work group. Among pregnancies ending in live births, hepatitis A vaccine was not associated with common maternal and infant adverse events, but a potential signal for small for gestational age births was identified. The observed effect size for SGA was an absolute difference of 4%, or 12.3% in vaccine exposed versus 8.3% in vaccine unexposed. General U.S. prevalence estimates for SGA are approximately 10%, and up to 14% among women of Asian race, who comprise 30% of the vaccine-exposed cohort in this study. The investigators in the work group considered that this SGA finding was likely due to unmeasured confounding and unlikely to be clinically meaningful. This study is expected to be published later this year. In the 2006 vaccine statement, it was stated that data on pregnancy were lacking, and as such, no recommendation was made. The proposed hepatitis A vaccine recommendation for pregnant women is as follows. Pregnant women who are identified as being at risk for hepatitis A viral infection during pregnancy or for having a severe outcome from hepatitis A viral infection, example, travelers, persons who use injection and non-injection drugs, persons who have occupational risk for infection, persons who anticipate close personal contact with an international adoptee, persons experiencing homelessness, and persons with chronic liver disease, persons with HIV proposed, should be vaccinated during pregnancy if not previously vaccinated. Pregnant women who are not vaccinated against hepatitis A viral infection during pregnancy should be counseled concerning other methods to prevent hepatitis A viral infection. This proposed recommendation for pregnant women is consistent with the vaccine schedule and parallel to the hepatitis B vaccine recommendations. Now I will talk about clotting factor disorders, which is proposed for removal as a recommendation. Persons who have clotting factor disorders have been recommended to receive the Hep A vaccine since 1996. However, the risk of hepatitis A viral infection has decreased over time, and the risk for viral transmission for persons with clotting factor disorders is considered the same as that for the general population. In the United States, greater than 80% of persons with hemophilia are treated with recombinant clotting factor concentrates, which are sterilized. Example, pasteurization, heat inactivation, or filtration, enabling these factors to be safe. Previously, some processes focused only on treatment with solvents detergents, which inactivated lipid envelope viruses, but not non-envelope viruses such as hepatitis A virus, resulting in a risk for hepatitis A viral infection. Secondary virus reduction steps are now common. During 1992 through 1993, several outbreaks of hepatitis A were reported in Europe among persons who had clotting factor disorders, who had been administered solvent detergent-treated factor VIII concentrates that presumably had been contaminated from plasma donors incubating hepatitis A virus. In the United States, data from one serologic study published in 1994 suggested that hemophiliac patients may be at increased risk for hepatitis A viral infection. During 1995 through 1996, several patients who had clotting factor disorders reportedly developed hepatitis A after having been administered solvent detergent-treated factor VIII and factor IX concentrates. The clotting factor recommendations from the 2006 ACIP hepatitis A vaccine statement kept part of the 1996 recommendations. Susceptible persons who are administered clotting factor concentrates, especially solvent detergent-treated preparations, should receive hepatitis A vaccine. However, the 2006 recommendation added that changes in clotting factor preparation practices and donor screening have greatly reduced the risk for hepatitis A for recipients of clotting factors. The ACIP Hepatitis Vaccines Work Group received input from the Food and Drug Administration and reviewed the literature on hepatitis A viral infection among persons with clotting factor disorders. No case studies of hepatitis A infections among U.S. persons with clotting factor disorders were found in the literature in the last 20 years. The work group considerations are as follows. Persons who have clotting factor disorders has been a risk group for hepatitis A vaccination since 1996. The risk of infection has decreased over time, and persons with clotting factor disorders are currently at an extremely low risk for infection with hepatitis A. No case study has been reported for any person in the United States infected with hepatitis A virus after exposure to clotting factors in 20 years. Secondary virus reduction steps are now common instead of solvent detergent treated. Many of the clotting factors now in use are recombinant. Source plasma is now screened for hepatitis A virus. There is no longer a specific risk of hepatitis A virus infection associated with clotting factor disorders. Therefore, this group may be removed from consideration as part of a high-risk population for whom hepatitis A vaccine is specifically recommended.
Do you have I'm sorry, forgive me, Dr. Nelson. Are there any questions? Yes, Dr. Alt.
Was there a registry study about pregnancy and the hepatitis A vaccine a couple of decades ago? There may have been when it was new. I don't know the answer to the
question. There was a 1998 study, registry study that also found no adverse events. I didn't present that today because it was used as evidence for the 2006 recommendation.
Dr. Cohn.
Will you make sure that when you update the pregnancy language that includes guidance for what to do with the catch-up recommendation for for adolescents younger than 18 who are pregnant?
Thank you.
Any other questions, comments? Yes.
Hi, Dr. Hahn from CSTE. I just wanted to ask, you mentioned that no published studies have mentioned clotting, or case reports have come out, but as you know, every case of hepatitis A in the United States, in theory at least, is investigated by local health departments and reported to CDC. And I didn't know if you queried state health departments or to see if they were aware of any or had reported any cases, because not everything gets published, right? So I just I wanted to mention that as another source to look at if that hasn't been done.
Thank you for that question. We did not query state health departments. We did work very closely with FDA to see if there had been any reports, and I'm not sure if any comments.
Any other comments or questions?
Okay.
Dr. Lee.
Just one quick question, and it relates to the ETR framework that came in the background documents. I'm just wondering if we can update the criteria for resource use and then actually mark it uncertain, because I really feel like we don't have enough to say, and then I think it just all depends on how you weight that domain in the overall decision. If we can mark that section as uncertain, I feel like it would more accurately reflect the information we have today prior to making the decision. Thank you.
Dr. Lee, can you just clarify that you're talking about the ETR framework for the HIV?
For the HIV, yeah, and I think that one of the things is thinking about the consistency by which we apply these criteria across recommendations, and so I thought about it also for the other one. I feel comfortable with it, but I just maybe we should also identify that a revised version of the cost-effectiveness model was not done to answer that specific question. I feel comfortable that it would be cost-effective, but I don't know if anybody else on the committee feels differently, if that should go to uncertain versus probably yes. I don't have strong feelings on that one.
Further comments or questions? Dr. Moore.
I think we'd be happy to consider that. I mean, it's a learning process for all of us as we learn how to use this framework consistently. So thanks for the feedback. And with respect to Dr. Hahn, I'd just say I think that the primary issue is that in conversation with the FDA, it was understood that the problem with clotting factor clotting factors themselves have been addressed, and therefore the risk of exposure from getting a clotting factor because you have a clotting factor disorder isn't there. And so it wasn't just that we just looked and we didn't see anything, but in fact the fundamental issues that had led to that being a risk in clotting factors in the past have been fixed through screening and through different processes for the manufacture of clotting factors. So that's more leading to the main reason why we think they're no longer at risk.
Yeah, I just want to respond to that real quick. Two things. First of all, the data said greater than 80%, so it doesn't sound like it's 100% that are using recombinant materials. And secondly, I just want to remind everyone that is a great data source that I don't think CDC always thinks to check, that these cases are investigated and there's great data, and often we don't hear it even mentioned as we looked at our own data.
Further comments, questions? Please continue.
Thank you. I will now review the proposed updates to the hepatitis A vaccine recommendations, which are in bold. Again, the proposed recommendation for catch-up vaccination is as stated. The full risk-based recommendations are shown here. It is proposed to remove persons with clotting factor disorders as a recommendation. Persons with HIV has been presented. An update to chronic liver disease is proposed. Clinical guidance is proposed to accompany the persons with HIV recommendation and includes information on response to vaccine, post-vaccination testing, potential need for IG for post-exposure prophylaxis regardless of vaccination status. We will consider the committee's comments in updating this clinical guidance. Next slide, please. For persons with chronic liver disease, the proposed recommendation update for persons with chronic liver disease parallels the hepatitis B vaccine statement. ACIP recommends that persons with chronic liver disease, including but not limited to persons with hepatitis B virus infection, hepatitis C virus infection, cirrhosis, fatty liver disease, alcoholic liver disease, autoimmune hepatitis, and an ALT or AST level greater than twice the upper limit of normal, should be routinely immunized against hepatitis A. The proposed recommendation for pregnant women is consistent with the schedule and parallel to hepatitis B vaccine recommendations and was previously stated. A new settings providing services to adults is proposed for the recommendation section. This guidance parallels the hepatitis B vaccination statement where applicable and includes settings where a high proportion of persons have risk factors for hepatitis A viral infection. For example, healthcare settings targeting services to people who use injection or non-injection drugs, group homes, and non-residential daycare facilities for developmentally disabled persons. This also provides guidance on vaccine administration and outreach in other settings, such as homeless shelters, syringe service programs, consideration of standing orders for routine hepatitis A vaccination, and vaccination of staff in facilities where hygiene is difficult to maintain. Recommendations for hepatitis A vaccination during an outbreak are proposed to be updated and include recommendations for pre-exposure hepatitis A vaccination of the at-risk outbreak population, pre-exposure hepatitis A vaccination in close congregate settings, providing services to high-risk persons in the vicinity of the outbreak, for example, persons incarcerated in correctional facilities, healthcare settings targeting services to people who use injection or non-injection drugs, homeless shelters, or syringe service programs. The pre-vaccination serologic testing recommendation section is proposed to be updated. Clinical guidance is provided, including specification of commercially available tests, and emphasizes that testing should not be a barrier to vaccination, and that vaccination should not be postponed if vaccination history cannot be obtained, if records are unavailable, or if pre-vaccination testing is not feasible. The post-vaccination serologic testing recommendations section is proposed to be updated as well. Testing is recommended for the persons whose subsequent clinical management depends on knowledge of their immune status. A new revaccination section is proposed, providing clinical guidance. Other guidance includes interrupted schedules and minimum dosing intervals and other immunization management issues and considerations. The language in these sections is consistent with previously published recommendations and the best practices guidance of ACIP. I'd like to acknowledge the following people and groups, and the proposed votes are shown here.
So we're going to have to go through each of the proposed votes, have a motion, a second, and then we will vote on them this afternoon. So let's begin with the proposed vote number 1. ACIP recommends that all children and adolescents aged 2 through 18 years who have not previously received hepatitis A vaccine be vaccinated at any age, i.e. children and adolescents are recommended for catch-up vaccination. Do I have a motion? Dr. Moore, go ahead.
I move that the ACIP accepts the proposed recommendation for routine catch-up recommendation for children as written on the screen.
Do I have a second? Dr. Walter.
I second the motion.
Is there any discussion, comment? None being, we'll move that forward for vote this afternoon. All right, proposed vote number 2. The ACIP recommends that all persons with HIV aged greater than or equal to 1 year be vaccinated with hepatitis A vaccine. Do I have a motion? Dr. Morgan.
I move that ACIP recommend that all persons with HIV aged greater than or equal to 1 year be vaccinated with hepatitis A vaccine.
Do I have a second?
Second.
Dr. Alt. Are there any comments, questions, clarifications? Yes, Dr. Talbot.
For the HIV population that doesn't respond, they may not respond because they have not had reconstitution of their immune system. And to me, it would seem very reasonable once they have return of immune function to try vaccination again. And I have a feeling that's a question that we will get a lot from HIV providers. I think in the clinical guidance section, I would have something to that effect. And the next question they're going to ask is, well, how many times do I try? So I think we need to have some guidance around that before we poke holes in people.
Thank you for that comment. Anybody else? Okay. We'll move this to vote in the afternoon. Final proposal for this area is ACIP affirms the updated statement, Prevention of Hepatitis A Vaccine Infection in the United States, recommendations of the Advisory Committee on Immunization Practices. Do I have a motion to, Dr. Moore, you're a motion machine, go ahead.
I would like to move that the ACIP affirm the updated statement, Prevention of Hepatitis A Virus Infection in the United States, recommendations of the Advisory Committee on Immunization Practices.
Do I have a second? Dr. Fry, please.
I second the motion.
Are there any questions or comments? Dr. Hunter.
I would just like to commend the work group on trying to harmonize things as much as possible with hepatitis B in particular, and especially when you're looking at a general issue of making medical condition definitions as harmonized between different recommendations for different vaccines as possible. I think practicing clinicians who do occasionally read down into that depth will be very, very appreciative of that.
Any other comments? If I may make a personal comment. Go ahead, Dr. Bernstein.
I just had a question, and I may be misinterpreting it. There was language about recommendations for hepatitis A vaccine during an outbreak, and it mentions children aged greater than or equal to a year on up. Now that we're giving hepatitis A vaccine or recommending it for 6 months through 11 months, if they're traveling outside the country in certain areas, should we be doing the same recommendation in an outbreak situation?
We did not consider a recommendation for vaccination below the licensed age for children who are in communities where outbreaks occur. It's a good question. We did recommend it for travel, as you may recall, because, or actually you may not have been here, because MMR vaccine is also given at 6 to 11 months of age prior to international travel, and we didn't want, normally hepatitis A immune globulin would be given because it's not a licensed product below a year of age, but in that case, we needed to recommend the vaccine instead if protection against hepatitis A was necessary, because you can't give Hep AIG and MMR vaccine at the same time because it interferes with the measles protection. So, so for a number of reasons, we did not go into recommending the vaccine for ages for whom it's not licensed in outbreak settings in the U.S.
Kelly, I think the other part of that is that are kids less than 1 year of age at risk for hepatitis A in the ongoing outbreaks?
Right. And so that's a very good point. The outbreaks that we're seeing from person to person are spreading among adults. Symptomatic hepatitis A is extremely rare in an infant. They may become a passive transmitter, they may be infected, but they don't get sick. So since there's not a health threat to those infants, protection of the adults is the focus.
Thank you. So in closing, I just want to say that I've been on the committee now for 5 years, and I'd like to thank Dr. Nelson for shepherding numerous changes to hepatitis A and updating it with today's standards. So thank you very much for that work. We will take a 10-minute break and return here at, oh, sorry. Forgive me. Please go ahead.
Sorry, I just had one question. In the chronic liver disease piece, you're talking about including people with ALT and AST greater than twice the upper limit of normal. That to me seems pretty low in a clinic on a clinical day-to-day work.
That language parallels exactly the hepatitis B vaccine statement and was deliberated on by the same work group for a number of times.
Dr. Atmore.
We see a lot of patients who have an acute illness that get their ALT more than twice normal. And so, I mean, that did give me pause also. It seems to me that there should be some chronicity associated with an elevated ALT and not in the setting of, say, an adverse drug reaction or an acute illness or something like that. So there needs, I mean, maybe that's not what, that can be in as a consideration, but it should not be something a clinician would say, oh, now I got to give it.
We'll be glad to take those into consideration. It's absolutely not intended for a temporary blip because of an acute illness. It's for something with an ongoing condition in the same way it's meant for hepatitis B vaccination.
Okay, we will take a break.